Thank you, Sumner, and thank you, Drew. This is a wonderful invitation. I'm only sorry that I wasn't able to be with you at the meeting today, so that's the sad news. But the good news is I just flew here from Austin, Texas. I was at the annual Congress of the American College of Lymphology, and what I'm delighted to say, and it's a kind of an icing on this cake, is that for the first time in its long history, they wanted a keynote speaker to talk about lymphedema. And I think that's terrific. One of the struggles that we've had, at least in the United States, for lymphatic medicine is finding an appropriate home, a clinical center that would encompass the things that we do when we're interested in lymphedema. And we really haven't had a comfortable home, but I think the vein specialists might really be prepared to enter into significant partnership with us, and that makes a lot of sense, as I hope I can underscore in some of my comments this evening. So just to tell you what I'd like to talk about, I'd like primarily to talk about a little bit of the function of the lymphatics in the broader context of edema. Make sure we're all on the same page about mechanistic hypotheses, talk a little bit about this wonderful circulation in particular, and then without spending too much time on lymphedema itself, because you've been talking about that all day, I'd like to talk a little bit about the research horizon, both in the broad perspective and then because I have the opportunity to stand at the podium, I'd like to tell you a little bit about some of our active research projects that are coming to fruition. So first I'll say I have no financial disclosures, and we'll get that out of the way. So as we all know, lymphedema has for all too long suffered from a recognition problem. The patients don't recognize what they have. The healthcare providers don't necessarily recognize what they have. And certainly if they do recognize what they have, they certainly are relatively ignorant about the diagnostic and therapeutic choices available to them. So let's start from the central topic of edema. Now, spoiler alert, this patient does have lymphedema, but at first blush, when we identify the fact that this limb has pitting edema, what we ought to be thinking is, what is the problem? Not all edema, to me, all edema probably looks like lymphedema, and I'm going to say it probably is. But in a broader context, we need to be sensitive to the fact that many mechanisms in the body will predispose to the development of edema, and it behooves us to understand the place that lymphedema holds in the grand panoply. But all of this, whether it has to do with the volume circulating within the blood, whether it has to do with the mechanics of the circulation itself, the permeability of the vasculature, at the end of the day, we're talking about the circulation. Now, this is a very simple schematic rendition of the cardiovascular system, and what I think we need to be interested in at the moment is this business end where arteries meet veins, because in the middle of that, of course, we have a capillary network. This network exists in every part of the body that receives blood flow, that is to say, all parts of the body, and this is where all of the fluid and solute exchange occurs. Hence, this is where the problem of edema begins. What we talk about once the fluid leaves the vascular space is what is referred to as the interstitium, or the space between the cellular content of the tissues. Now, this space is a very intricate arrangement that will allow for what needs to happen. And I want you all to acknowledge that fully 1/6 of the total fluid volume in the body is present in this interstitial space. And that fluid has the name of interstitial fluid. If it enters the lymphatics, that same fluid changes name and is called lymph. But when it's in the interstitium, it's not yet lymph. And I want you to be aware of the fact that this space is full of proteoglycan filaments that trap water into various compartments. So don't think of this as a water-filled balloon. This is actually a gel in which everything, including the water movement, has to happen by diffusion. So what happens as there is an equilibrium between what's in the blood vessels and this space, was described more than 100 years ago by a physiologist named Frank Starling. And I want us to think about what he thought at the time, and I also want us to think about the ways in which we may need to revise what he said. So he recognized the fact that there were 4 opposing forces at the level of the capillary that will determine whether water wants to be inside of the vessel or outside. So we have hydrostatic forces. The one inside the capillary wants to drive the fluid out. The force within the interstitium wants to keep it within the capillary. And then we have opposing forces called oncotic pressures that represent the impact of the large molecules on the movement of water. So oncotic pressure within the vessel wants to hold the fluid in, and vice versa for the interstitium. So the balance between these 4 forces will determine the directionality of fluid movement out of the capillary. Now, if you look at the left-hand portion of this slide, you will see what Starling actually described. He did quantitative analyses that allowed him to come up with a formula to predict how fluid would behave in the capillary. And he came up with a strategy that said basically fluid's going to want to leave the arteriolar end of the capillary to carry oxygen and solutes with it into the interstitial space. But as fluid leaves the capillary, you will start to hyperconcentrate the proteins that are left behind, and eventually that oncotic pressure within the capillary will create an equilibrium in which fluid movement will cease, and eventually then the net fluid movement will go in the opposite direction on the venular side of the circulation, drawing the fluid back in. This is the classic notion of how the circulation behaves. It's very elegant and it's very pretty, but it turns out it's not quite correct. Starling did correctly identify all 4 of the forces involved, but he made one mistake. He assumed, because it was almost impossible to measure, that hydrostatic pressure in the interstitial space was effectively 0. And if you make that assumption, then the model will work exactly as you see on the left-hand portion of the slide. However, with more elegant technology that is available today, we can actually make empiric measurements of the pressure in the interstitial space. And while it's very low, it's not 0. And when you use those measured values and plug them into the Starling equation, you find that, in fact, there is a net movement of fluid outside of the capillary all the way from the arteriolar end to the venular end of the capillary. And what that says, in essence, is that the veins do not participate effectively in fluid return from the interstitium back to the heart. So I'm going to go back to what I said originally. In essence, what this tells us is all edema is lymphatic edema, because any ability to accumulate fluid in the interstitium in excess represents the failure of the lymphatic circulation to take that fluid back to the heart. In fact, with every passage of a unit of blood through the arteriovenous network, 1% of the water content of the circulation will end up in the interstitium and will require lymphatic transport to return to the heart. So we need to revise this elegant schematic and make sure that we include all of the information. And what I want us to pay attention to at this point, because it is such a vital part of the function of the circulation, is the network seen here in green. If I can make the arrow go there, I don't know that I can. But you can see that in addition to that 99% of fluid circulation going from artery to capillary to vein, there is 1% that has to travel through the lymph. And in so doing, it will percolate not through just one, but through many lymph nodes, which will allow this system to actually perform its true function, which is an immunovascular function. It not only provides for circulatory balance, but because all of this fluid, which is carrying vital cells and cytokines and chemokines, has to percolate through these lymph nodes, this is a way to traffic immunologically important information so that the immune system can actually respond in an appropriate way. So I hope I've made the point that while somewhat ignored by clinicians over the decades, this is truly a vital part of the human function. So this is a metaphor that I often use when talking about the lymphatics. I ask all of us to look at this picture of a brick wall, and what we see is a very neatly arrayed set of rows of rectangular maroonish objects. That's what we see, but we don't often pay a lot of attention to the white mortar in between these bricks, but as we all know, without mortar, you just have a pile of bricks. And I submit to you that the lymphatics represent the mortar of the circulation. This is what holds it all together. This is what allows it to function. So with that in mind, I think I can talk about a few vital functions of the lymphatic circulation. Number one, as we've just said, it has a job to maintain the balance of fluid within the various compartments of the body because of its function in removing excess fluid from the extracellular space. In the gastrointestinal tract, which we won't talk about very much tonight, it has a vital function. We cannot absorb nutritional lipids from the gastrointestinal tract without the lymphatic circulation of the gut. This is the obligatory pathway, not only for nutrients, but also for the fat-soluble vitamins. And finally, as I said earlier, we need the lymphatics to subserve that immune trafficking function that is so vital to preventing infection and to surveillance by the immune system of the health of the individual. I like to also think about a broader concept related to the lymphatics, which is what I've called the lymphatic continuum. So we've just until now been talking about the circulatory and to a degree the immune function of the lymphatics, but let's bear in mind that well beyond lymphedema or any vascular manifestation of lymphatic disease, there is this much broader fabric of health and disease that is served by the lymphatics. And this relatively small list that I've put up here represents actually just a fraction of the very important disease states for which there is either a pathogenetic role for the lymphatics in the development of the disease or the maintenance of the disease, and or the therapeutics of these diseases. This is a burgeoning area of medical science that will come to fruition, I hope, within the next decade. But we're going to be relying, I predict, increasingly heavily upon the lymphatics to allow us to do our broader job as clinicians and healthcare providers as we embrace the broad fabric of human disease. So with all of that in mind, let's start to focus some attention on the lymphatics themselves. They have an extraordinarily elegant structure, and I don't have time to go into vast detail, but bear in mind that the system is designed, number one, to have this vascular network in close apposition to the interstitium. This is really a very intimate relationship in which the actual lymphatic endothelial cells that line the capillaries of this system directly interdigitate with the interstitial space where the fluid and macromolecules accumulate. And as this system arborizes into larger and larger vessels, eventually it becomes invested with a smooth muscle coat that will allow it to undertake its autocontractile function, which is also extraordinarily elegant, and I hope to show you an example of that in a moment. So looking at it more schematically, we start with these blind-ended pouches of overlapping lymphatic endothelial cells, which coalesce into these larger structures, initially called precollectors, when they start to show evidence of valvular apparatus within them, and ultimately acquiring that muscular coat that allows them to be the fully functional conducting vessels that will carry this fluid rapidly and efficiently back to the heart. If you do a lymphoscintigram in a normal human leg and you inject radiolabeled material into the interdigital space in the toe, you will see appearance of the material in the inguinal lymph nodes in as little as 5 minutes, working against gravity just by the autocontractile behavior of these vessels themselves. It has been described that the intercellular junctions within the lymphatic network allow a lot of this magic to happen. So these have been fancifully called buttons and zippers. The buttons exist within the capillaries themselves, where we have lymphatic endothelial cells that are very loosely connected to one another, and the tight junctions are very widely separated, which allow the interdigitating oak leaf cluster arrangement to open and close at will. So as interstitial fluid pressure increases, these oak leaf clusters are drawn apart, the flaps open, and just by convection, large amounts of fluid carrying macromolecules and debris and actual cellular contents can flood into the lymphatic space where they are entrained. Eventually, as the material is pulled upstream, we get to the portion of the vessels that are lined not by buttons but by zippers. These are still lymphatic endothelial cells, but now the tight junctions are dispersed completely between adjacent cells, so there is basically no permeability. Once entrained within the lymphatic circulation, in principle, the fluid and its contents remain within the vascular space. All of this can happen because at the level of the capillary, these lymphatic endothelial cells are attached to the surrounding interstitium by what are called reticular filaments, and you're looking at these under the electron microscope. These filaments are about 100 nanometers in diameter, so as you can tell, exceedingly small, but they work a little bit like parachute strings. When the interstitial space is decompressed, these filaments are not taut. They simply are loosely aligned as you see them here. But as fluid accumulates, the principle is that these reticular filaments experience increasing pull, and because they're attached to the endothelial buttons at the other end, they pull these openings apart, these interendothelial openings that allow the mechanism to occur in such an elegant fashion. So lymphatics live side by side with the blood vessels. Here we've done an immunohistochemical stain where blood vessels are green and lymphatics are red. You can see lymphatics are slightly larger than the comparable microvasculature on the blood side, but this is the arrangement in which everything can happen. So let's zero in a little bit closer on the lymphatic vessel itself. Now you're looking at a conducting vessel. You can see the valves subtending this vessel into its functional parts called lymphangions. So one segment of a lymphatic collector bounded on each side by a valve is called a lymphangion, and these lymphangions work in series to propel the fluid upward up the chain because of the autocontractile mechanism. I also want to draw your attention to the adipose cell environment in which this lymphatic vessel lives. It turns out, if you look through the human body, you will not find a place in which you will see vessels like this where there is not a sea of fat surrounding it. There is a close, intimate relationship between lymphatic biology and adipose biology. As you undoubtedly will have heard today and will hear tomorrow, we're only just beginning to scratch the surface of all of this, but herein lies the magic of the surgeries pioneered by Dr. Rockson to my left for the adipose complications of late-stage lymphedema. Herein probably lies a lot of the mystery surrounding lipedema and many, many other attributes of lymphatic biology. We don't understand it yet, but we know that there is very important biological crosstalk. I want to give you the opportunity to see what lymphatic autocontractility looks like. If I can make here we go. So here you can see the valve in the center of the image, and this is the vessel propelling fluid under its own steam. This is how this really magical circulation is able to work. So I hope I've convinced you that the lymphatics hold maybe not a central place, but a very important place within the function of the circulation, but also, as I've alluded, and I haven't really had time to demonstrate to you, there is this very, very important immune function as well. So I can hardly imagine a function of the human body that could be more compelling than sitting at the crossroads of two extraordinarily important systems such as these, the circulation and the immune system. It begs understanding about how this circulation can have been so roundly ignored for so long, but I think that history is over. The reason we're all here is because we all now understand we need to understand it better, and we need to be able to treat the diseases that afflict it. So just to give you some quantitative information, the lymphatics carry about 25 milliliters per second of fluid transit. They occupy about 3,500 kilometers of real estate within the human body. And at any one time, they contain about 2 liters of fluid. So that's roughly 40% of the cardiac output. That is not at all a trivial finding in terms of the circulatory balance. Again, we need to have some respect for that. Same thing. So when moving on to the topic of lymphedema itself, I like to think about lymphedema as the failure state of the lymphatic circulation. When it occurs in a part of the body, of course, it's regional. It can happen throughout the body in some of the complex inherited diseases that affect the lymphatics. But as clinicians, we're very used to thinking about system failure diseases. So as a cardiologist, you heard earlier that I'm a cardiologist. We know that the heart can fail as a pump, and then we have a syndrome that we call congestive heart failure. If the pancreas fails in its endocrine function of insulin delivery, we see diabetes, and so on as you go down the list. And when we see the lymphatic system fail in its circulatory function, we see the disease of lymphedema. So hearkening back somewhat to an image or type of image that I showed you at the very beginning, here is a patient with upper extremity lymphedema in relationship to breast cancer. So this represents one type of lymphedema that we see, what we can call the obstructive form of lymphedema. We know that to contain cancer and to stage it, we are forced iatrogenically to damage the lymphatic system. And as a result, depending on when you look and who you read, somewhere between 15 and 30% of survivors will develop this problem. Mechanistically, conceptually, this represents an imbalance between two important forces that we think about. The lymphatic load, or you might think of it as preload, is the amount of interstitial fluid formed per minute in any region of the body, and the lymphatic transport capacity represents that net effect of the lymphatic circulation to carry that fluid back to the heart. Whenever the lymphatic load is greater than lymphatic transport capacity, you will have net accumulation of fluid. Now, in this case, the lymphatic load is normal, but the lymphatic transport capacity has been reduced. It has been iatrogenically reduced. The net effect, however, is the accumulation of fluid, which sets into motion that inexorable set of consequences that we recognize as the broader problem of lymphedema. This was a good image to show the phlebotomist this morning because this man has lymphedema, but if you look closely, he has a very reddish right lower extremity. He has dependent rubor of the leg. This man has venous disease, and as a consequence of venous disease, he has developed lymphedema. So chronic venous insufficiency leading to a secondary form of lymphedema. And this represents not the obstructive form, but one in which the lymphatic load has been dramatically increased and has overwhelmed an essentially normal lymphatic transport capacity. So we would say in principle this man had a normal number of lymphatic vessels, normal number of lymph nodes, but because of the venous hypertension engendered by his structural disease in the venous system, that lymphatic load went up because of the increase in pressure at the venular end of the capillary, hearkening back to Frank Starling's relationship. So we need to be sensitive to the fact that lymphedema exists across the spectrum. We see predominantly obstructive forms, but these other forms also exist, and many forms exist as a mixed picture as well. However we get lymphedema, the consequences are severe. We know that all of the things listed on the left-hand portion of this slide do happen to lymphedema patients, and I can only conjecture that all of the things on the right-hand side, which are again well documented in prospective studies, are a consequence of these structural abnormalities. The biology of lymphedema is complex. When we develop lymphedema, whether it's obstructive or the other form, we set in motion the biological responses to the edema accumulation, and this is what we see as the end consequence. I'd like to spend just a couple of minutes to allow one of my patients to tell you pretty eloquently, I believe, what it means to live with lymphedema. This woman actually is a nurse and a hospital administrator, so I think you will hear how articulately she expresses what she lives with as a consequence of having acquired breast cancer-related lymphedema.
Tell me everything you can in a minute or two about the problem that you have with lymphedema.
Well, lymphedema is really a life-altering, progressive process that you can be the most compliant in the world, and that's not going to gain you access to stopping the progression of the disease. It is ever present. I can't walk down the street without somebody looking at my compression device and saying, "What happened to you?" I can't hug my husband at night because my Joby pack is so big and I have to wear it covering my chest wall and my arm, and I feel like I'm wearing a baton at night. And so, snuggling is a very different thing than it used to be before the breast cancer. It is, I'm always on alert for cellulitis. It has impacted our travel. I'm afraid to go on long airplane trips because I know that 4 or 5 days after a long flight or even significant up and down in flight, that my arm will be worse and I'll have to spend more than the 2.5 hours a day that I was already spent taking care of it. And there's a net risk gain associated with how much time I have to take care of this arm and this breast and this back, and that's that I'm on the couch for 2.5 hours a night. I would rather be walking. What happens when I miss that social time in the evening? My evenings are about lymphedema. I have dinner, my husband does the dishes, and I go upstairs and begin skincare and decompression, and then it's the nighttime garments. He goes to bed by 9, and by the time I'm done with everything, it's 10:30 or 11. And that's how I spend my evenings. I don't like it. I want my life back.
So I'm not going to spend a lot of time, or any time actually, talking about current clinical practice. I believe this is an initiated audience, and this patient spoke to elements of what are available now. I will not denigrate the fact that these treatments reduce the impact of disease, improve function, and help us to halt progression, but we all acknowledge it may not be the ending place for where we want to be. It does allow us to return individuals to functional roles within society, within the home, within the family, but one of the problems we face, at least here in the United States, is that the healthcare system is not even readily prepared to deal with these patients. I think it's appalling that in 2017, Medicare does not recognize that lymphedema should be treated with compression garments and consequently will not pay for them. This is only one of many major affronts. And I know there's been a lot of discussion about surgery today, and of course that's an uphill battle that we fight week in and week out for the patients in whom we think a surgical solution may be helpful. I do want to move on to the topic of research. I want to talk about some elements in general and then just spend a few minutes to let you know about a couple of the exciting projects that we're able to undertake in my program. So I would say the dawn of the major breakthrough in research throughout the world was around this time of 2001 when Nature Medicine, many of you know that's one of the most prestigious biomedical journals in the world, chose to feature the topic of lymphangiogenesis as this cover article of this issue. And this is about the time that the cauldron started to bubble. More recently, equally, I think, or nearly equally prestigiously, in 2014, the Journal of Clinical Investigation chose to devote an entire issue to invited subjects related to the lymphatic vasculature, including lymphedema. So this was a huge, huge breakthrough. I was mentioned earlier, I have the privilege to serve as editor-in-chief of this peer-reviewed journal, Lymphatic Research in Biology. We're into our 14th year of publication. I'm happy to say that the queue of submitted manuscripts has grown so large that we've had to increase the number of issues per year that we publish. We have been historically a quarterly journal. As of the 1st of January, it will be a bi-monthly journal. And for those of you that are vitally interested in this topic, I heartily encourage you to pay attention to lymphatic research in biology. It is an area in which a lot of new information is being promulgated, and the impact factor of the journal rises steadily year by year. As you heard, we're making wonderful inroads at the National Institutes of Health. I have had the privilege of helping to organize a trans-NIH coordinating committee for lymphatic research that cuts across the various institutes at the NIH. This was a meeting that we held intramurally several years ago to talk about the intramural research being done on the NIH campus related to lymphatics. I'm happy to say that the National Heart, Lung, and Blood Institute has actually listed lymphatics as part of their mission statement. That was a little bit of an uphill battle, but one that we won. And the future for grant proposals looks reasonably bright. It has to get better, but it's looking better than it ever was at the NIH. The National Library of Medicine, which catalogs the indexed papers that are written, you can see that in the early 1940s there were single-digit numbers of publications related to lymphatics, and of course if this were a profit curve for a business, we'd all be jumping up and down in exultation. We're now edging up to 6,000 publications per year, so truly an exponential growth in the interest within the biomedical literature for the field of lymphatics. I'm happy to say that our textbook, many of the people in the room were contributors to both the first edition and the second edition. The first edition was successful enough that the publisher came to us and asked us to revise it. The second edition will be released on December 4th by Springer London. We've expanded the content, I would say, by at least 10%, embracing lots of new subject matter. And again, for those of you that are interested in this topic, I think you will find a very nice, concise, albeit not so short, introduction to the field. I think the text is going to weigh in at about 700 pages now. So, but if it's not in there, you may have a hard time finding it elsewhere. So that's a good thing. So talking about a couple of our projects to end. One of them is surgical, one of them is pharmacological. I'll start with the surgical one. Of course, everybody in the room is well initiated now into the topic of the surgical approaches, or the microsurgical approaches to lymphedema, one of which is autologous lymph node transfer, as is shown schematically here. The notion being that you can harvest a healthy lymph node and transfer it to a compromised portion of the body. And the presumption is that the lymph node acts primarily as a source of lymphatic regenerative repair, because the lymph node is such a tremendous factory of growth factors, so that once it becomes incorporated into the lymphatic circulation in the host region of the body, it can help to orchestrate repair that can reduce or eliminate garment requirement and some of the other things that the patient complained about in the video. The field is progressing, but as we all know, the outcomes are still not universally successful. And one of our interests has been to try to determine whether we could improve the success surrounding autologous lymph node transfer. The notion is that when the procedure is not successful, one of the limiting factors may be the rate of engraftment of the lymph node into the lymphatic circulation. So the surgeon, of course, will ensure the arteriovenous supply of the transplanted node, but the connection to the afferent and efferent lymphatic vessels must occur by direct extension from the surrounding tissue. So herein comes our quest to do something with this. I've had the great fortune to work in partnership with a company in the Bay Area called Fiberline, and Michael Paukstow is here this evening. And together we have helped to develop this, what we conceptualize as a biological scaffold. It is composed of highly aligned normal mammalian collagen fibers, eventually creating a structure that you see on the left-hand portion of the slide that is able to be incorporated into the surgical field by direct apposition, not suturing to the lymph node, but being placed adjacent to the lymph node, both on the afferent and efferent side, to serve as a bridge or scaffold between the existing lymphatic vasculature and the transplanted node. You see the fibers en face and then in cross-section under the electron microscope. And the wonderful thing about this BioBridge scaffold is that when you expose it to human lymphatic endothelial cells, they are highly encouraged to grow across this medium. And if anybody has ever looked at electron micrographs of the interior of any kind of blood vessel, you will recognize this as normal, healthy lymphatic endothelium, because these cells will align themselves in a single direction with an overlapping configuration of the type that you see here. So with this in vitro observation, we were very encouraged to pursue a large animal model to look at chronic lymphedema, and without going into great detail about that, this study is now published. We see that the use of the BioBridge scaffold can reverse the objective measurable elements of at a macroscopic level of the lymphedema, and microscopically we see the new development of lymphatic collectors in apposition to the collagen fibers. You can see them there as the darker pink strands on the right-hand portion of the histological image. Bear in mind that this is normal collagen, and we do have evidence that all of it actually is resorbed over a 6 to 9 month period of time, but we pass through a transition when this inert material from an immunological perspective is able to stimulate the growth of these new lymphatic collectors that you see in apposition. And if we do immunohistochemistry on these structures, we can see that they are indeed lymphatic collectors because they are lined by lymphatic endothelial cells, and on the exterior surface have smooth muscle cells appropriate for a collector. I'm delighted to say that the clinical trial of the BioBridge is underway. It is a phase 2 investigation. We've been given an IDE status by the FDA, and I'm even more delighted to say that the National Cancer Institute has funded this project over a 3-year period of time. The project has been launched at Stanford. We're hoping to incorporate 3 or 4 additional sites and hope to be able to demonstrate with this study that, in fact, the BioBridge holds promise for the future and improves the outcome of autologous lymph node transfer. Moving on to the last topic, this relates to my long-standing interest in comprehending what the tissue response is to chronic edema. So we talked about the fact that once you invoke edema, whether it's by an obstructive mechanism or an increase in lymphatic preload, you eventually invoke a tissue response that represents the broad spectrum of the disease. And what we were able to demonstrate early on is that this expression profile of the tissues is heavily predominated by inflammatory signals and signals related to the immune system. In fact, it's pretty much all of it in the mouse model that we look at of chronic lymphedema. But we repeated the work in human lymphedema skin, and again, we're able to show that while there is some signaling related to the adipocytes, very important, of course, in the biology of lymphedema, there is some signaling related to vascular repair, but almost all of it, again, has to do with inflammation. And with that in mind, we undertook some semi-empirically driven studies, first in the mouse model and then eventually in human subjects, to look at abrogating the inflammatory response as a way to change the outcome of the disease. And what we were very gratified to learn, and this really is a paradigm shift in a way. We've always said historically that we want to treat lymphedema physically in an aggressive fashion to prevent its progression to the irreversible stage. Well, it turned out that when we looked under the microscope, when we used an anti-inflammatory approach appropriately, we not only relieved edema in the mouse model, but we actually did return the histology to a relatively normal appearance in a relatively short period of time. So on the left-hand portion of the slide, you see lymphedema skin with a dramatically increased thickness of the epidermis and the dermis, huge inflammatory cell infiltrate dilated lymphatic microvessels. On the right-hand portion, you see what the normal skin should look like. And in the middle, you see a mouse that looked like the one on the left and then was systemically treated for 2 weeks with an anti-inflammatory drug and then sacrificed for the histology. And you can see that the histology has nearly completely returned to normal over that short period of time, and the edema resolves as well. This work allowed us ultimately to identify a much more targeted drug, which we are studying avidly. It is a drug that has been used for 30 years in Japan for another medical indication, but has an overlapping mechanism of action to one that we're interested in, namely the blockade of production of an inflammatory mediator called leukotriene B4 or LTB4. And basically, when we block leukotriene B4 production in the same model I just showed you, now we're looking at what is effectively a lymphoscintigram in the mouse tail. On the left-hand portion, you see the normal pattern of the interdigitated capillaries filled with the fluorescent material. In the middle, you see what happens in lymphedema. Basically, the structural integrity of the microvasculature breaks down. We get what is called clinically dermal backflow, or the pooling of the lymphatic fluid in the tissues. And on the right-hand side, you see a mouse that, again, was treated for 2 weeks systemically with the leukotriene B4 antagonist, no other therapy, and you can see almost complete restoration of the lymphoscintigraphic anatomy to normal that couples with the functional improvement. Now, we've been able to show in the mouse model that this relates significantly to removing the barriers to lymphatic repair. So we find that LTB4 blocks VEGFR3 signaling, which is unique to the lymphatic endothelial cell, and it blocks Notch signaling, which has to do with maintenance of lymphatic integrity. And by blocking LTB4, we can basically allow the lymphatic circulation to repair itself. At a more functional level, I want to show you what that looks like on near-infrared fluorescent imaging. I know you've undoubtedly heard about that today. Let me show you the control-treated animal first, if this will play. What you will be looking at is, on the right-hand portion, is the lymphodematous part of the tail. In the middle is where the surgical intervention was performed. And what we're looking for is flow in the lymphatic collectors moving to the left, to the opposite side of the surgical field. And I think you can see that basically we don't see anything. So we inject the material distally to see if it can transit to the proximal portion of the vessel. Now, this is the animal treated systemically with the leukotriene antagonist. And here you'll see, in a matter of a few seconds, reconstitution of the lymphatic collector on the proximal side of the tail, indicating that flow through the tail has been restored through the pharmacotherapy. So this is very exciting. Not only can we show functionally that flow ability returns, but also at an ultrastructural level, we see that the end organ damage reverses itself in an appropriate fashion. So here again, I'm delighted to say that we have active clinical trial underway. This is a phase 2 investigation, again, under the auspices of the FDA. We are studying lymphedema, acquired and primary lymphedema in the leg. In this particular study, Stanford is the lead site. We have 2 other sites in the United States and 1 in Sydney, Australia. We will complete the projected enrollment within the next 30 days, and therefore, by late summer, we should have acquired all of the data for these patients who are actively in the trial for a 6-month period of time after screening, and hope ideally to have some initial analysis of the data by next fall, which will determine whether we can proceed with additional studies. We have on the drawing board potentially studies of primary lymphedema, as well as studies in head and neck lymphedema and breast cancer-related lymphedema if this initial signal trial shows proof of concept. So with that, I'm going to allow us to all get out of here and eat dinner. I just wanted to say, in summary, there's a lot that we can do for lymphedema patients today. We can provide stability, we can provide slowing of progression, we can provide improvement of function, we can provide acknowledgement and recognition of their disease state, which is already a very big step that's been lacking for a long time. But there's a lot of progress that we need to make. I think the research horizon is very robust. A lot of things are happening. I can talk only most knowledgeably about what I'm doing, but I know there is work going on throughout the world, and I hope that if and when we can reconvene in maybe 3 to 5 years, we'll be talking a very, very different story. So thanks very much for the invitation and for your attention.